Three, two, one. Hello and welcome to this Care Leaders Network podcast. My name's Simon Parker and I'm the founder and chief executive of CLN. And I'm welcomed here today by Kreshnik Hoti from PainChek. Great to have you on the podcast today, Kreshnik. We've got a big and important topic to talk about. Do you want to just start off by giving people a bit of an introduction into you, your background, and a little bit about PainChek as well?
Hi, Simon. It's nice to be here. So my name is Kreshnik. I'm from PainChek. I'm a co-founder and a senior research scientist at PainChek. And my other role is I'm an academic. So I'm a professor in pharmacy at the University of Pristina, and I'm a university associate at Curtin University in Australia. So that's my background. Otherwise, I'm specialized in medication reviews. So my background is in pharmacy. I'm a pharmacist, and I've done a lot of medication reviews in geriatric setting, community, as well as aged care settings, institutionalized. So that's in Western Australia, where I've reviewed quite a lot of medications, including obviously medications in people living with dementia there. And I'm from PainChek. As you know, PainChek is the vision and mission is to really improve how pain is identified and therefore managed. And by doing that, we strive to sort of ensure that no one silently suffers from pain. So that's our key mission. So that's briefly about myself.
Perfect. Thank you for that. So the title that we agreed for today's conversation is why we should focus on pain when addressing, we put it in quote marks, challenging behavior. Even the terminology around challenging behavior is something that's actually being challenged at the moment. But I guess put that into context for us, because it's a super important topic, but I think it makes sense to be able to set the context for today's conversation as well.
Yeah, well, that's a good point, Simon. Now, obviously, challenging behaviors are quite problematic. But before we go into the specifics, I mean, we can talk about the language which is used to really describe these behavioral symptoms in people living with dementia, and I think that's really, really important. The way we talk about in dementia is quite important. I mean, the way we talk about dementia in general, but also when it comes to behavioral symptoms, it's very important to use positive language, the right language, because that can obviously have a direct effect on how people living with dementia feel as well. Now, we are in the clinical context, we are very well familiar, I guess, with a terminology that's called behavioral and psychological symptoms of dementia, otherwise known as BPSD, which, as I said, is a term commonly used in the clinical context. I think this is quite a medicalized terminology as well from that perspective. Obviously, people living with dementia are in positions or settings that are outside of the clinical context. And that's why there are a number of other terms that describe behaviors that are basically challenging in this population group. And according to Alzheimer's Society, there are a number of these terms, and they include terms like changes in behavior, challenging in behaviors that challenge, symptoms of distress or distressed behaviors, and so on. So these are all terms that are used to describe what you just mentioned, challenging behaviors. But we shouldn't really use terms like difficult behaviors or being difficult. That's what the Alzheimer's Society also recommends in order to use positive language in dementia. Also, what's really interesting, what's been happening in this area is the fact that there's slightly a shift from moving away from strict terminology, for example, of using challenging behavior, because sometimes it can, or at least use this too much, because sometimes this puts an emphasis on what is our experience or carers' experience with these behaviors. And that is why terms such as distress behaviors nowadays, they're being used increasingly more because obviously, first of all, often these behaviors are caused by distress, and also a terminology like that puts an emphasis on how the person is experiencing these symptoms and basically what's going on with them. So this, from the terminology perspective, I believe delivers more, or assists, facilitates that person-centered care, if you want. So here in this context, the person living with dementia is at the center. So that's in terms of terminology.
Sure, no, and that makes total sense. I think there's a real big shift in the social care world in the UK at the moment, which is one of shifting from a compliance mindset through to a quality of life mindset, and it's underpinned by, of course, person-centered care. But it's almost like the kind of almost like the philosophy of the care organizations, what kind of language they use and things like that, to be able to. Compliance is important. You need to kind of tick that box and make sure that those things are kind of squared away. But ultimately, in the world of care, you're looking after people, and I think that challenging behavior, both the phraseology and the mindset that sits behind that, seems somewhat old hat. So the fact that we're now reframing that almost in the context of distress behavior. Again, it's looking down the lens, or looking through the context of it being a more person-centered description, because the person. Nobody wants to have quote unquote challenging behavior. You know, we've all maybe all had a bad day where we've shouted at a loved one, or one of those similar sets of circumstances. You don't feel good being in that set of circumstances. So to be then labeled as being challenging, that's not going to add anything to the set of circumstances. So being more compassionate in the way that we describe people's life experiences, I think is a really, really powerful thing to do. And it links so beautifully with the conversation that we're having today around helping understand people who are living with dementia, people who are experiencing pain, and helping them to be able to make sure that their life experience is the best that it possibly can be. Because it's one thing if you're in pain and you're able to communicate that pain to somebody to be able to remedy it in some way, shape, or form. But if you can't do that, you're quite literally suffering in silence. So really excited to get into the conversations around this today. So let's start with my first question. So what's the relationship between pain and behavioral and psychological symptoms of dementia?
Well, Simon, behavioral or emotional state changes are very common in dementia, and they include various changes such as aggression, agitation, shouting, and so on. When it comes to BPSD, they also include issues such as apathy, depression, and so on. Now, what the literature data suggests is that over 90% of people that live with dementia, at some point they experience BPSD. So the problem when it comes to pain is that these symptoms are actually often caused by pain. Obviously, there's other causes for these symptoms, not just pain, including their anxiety, various frustration, living alone, etc. Nonetheless, these changes in behavioral or emotional state, they reflect a physical or emotional need, or basically a feeling which otherwise they're not able to communicate. So, and often these behaviors can be quite distressing, not just for them, but for the carers as well. They're very challenging for the person that experiences them, but also challenging in terms of identifying what is causing them. This is the link with pain and when it comes to behavioral symptoms in dementia, because pain is also very prevalent in aged care setting in general. Now, various data suggest that over 90% of residents living in aged care at some point experience pain, and around 50% of them have pain most of the time. Now, Also, various studies suggest or indicate that up to 50% of people living with dementia, they regularly suffer from a degree of pain. Now, this is a problem, because we really need to make sure that basically we're able to identify pain in this population group. We also have research that suggests that puts a direct link towards the levels of pain as well as the degree of severity of these behaviors. It's interesting because according to this research, people that are in pain can have a 3.8 times fold increase in the likelihood of these symptoms being experienced. That's quite significant, Simon. But also the severity of these symptoms is higher in this group. So people who are in pain and their pain level is higher, the severity of behaviors is higher as well, and this causes significant distress for not just for the person with dementia, but also to caregivers as well. And according to this research, over 30%, that's over 30% more distress to caregivers. So there's clearly a link between pain and dementia, especially when it comes to behavioral symptoms. And we really need to make sure that we identify pain properly, so we don't leave pain as a cause of behavioral symptoms which is not being identified and therefore treated. I think this is the key link that we need to focus and resolve, really.
And talk to me about why pain is difficult to identify in people who are unable to reliably verbally communicate.
Yeah, well, that's a great question. Now, there are a number of challenges when it comes to pain identification in people living with dementia. Firstly, we know that people living with dementia, they progressively lose the ability to communicate. That's including communicating pain. So basically, they lose their ability to self-report pain. And we know that verbal self-reporting is basically the primary method or the golden standard by which we communicate pain. We also learn to self-express our pain. Therefore, these abilities, these behaviors are slowly and progressively lost. So the biggest challenge is this. So the fact that people with dementia, especially those with advanced dementia, they're unable to communicate pain and therefore self-report. This is the key difficulty. Then obviously people with dementia, they also tend to lose their ability to regulate their already learned responses to pain, especially as their condition progresses. When we are children, as individuals, we learn to suppress the urge of cry or shout whenever we experience pain. And this is lost due to progress of dementia. And the way we treat these behaviors, we respond to pain is basically gradually diminished and lost. Then we have the issue of subjectivity of pain itself, which also applies here, and there's a lack of documentation of pain. This is another big problem in the area. There's studies that suggests that basically we need better documentation. Nearly 1/3 of residents have no documentation of pain and how it was identified. So that's an issue. And these studies, the literature, various literature data out there recommend incorporating plans or incorporating proper documentation of pain, of how pain is identified and therefore how it's treated. If we don't have a good documentation of pain, our management, firstly our identification, but also management of pain in general is not going to be optimal. Then another issue specifically in dementia, and what the studies suggest, is that over 40% of care professionals receive no training on how to assess pain in someone with dementia. Because they obviously lose the ability to self-report, that also means that the pain assessment needs to be multidimensional. So you need to assess their face, their facial expressions, their vocalizations, behaviors, body movement, etc. So there's some skills involved in that. And over 40% of care professionals, as I mentioned before, report that they've received no training on how to assess pain. This makes identification of pain in people living with dementia more difficult. So, and this is a problem that also needs to be addressed in order to us properly first identify and therefore treat pain, Simon.
Great, thanks for explaining that. One of the things that I was thinking about whilst we were discussing that that came to mind. So obviously there's a lot of debate around the use of antipsychotic drugs, particularly for people living with dementia. It seems to be the tide seems to be turning on the how people are prescribing antipsychotic medication and other medication as well for people living with dementia. And I guess this links back to this to the point around pain. So to what degree does an identified pain lead to inappropriate prescribing, would you say?
Well, Simon, that's a great question. I mean, the difficulty or the challenges in identifying pain, we know that that's associated more with inappropriate treatment of pain in general. So that's what the literature data suggests. So this is really a big issue. I mean, I remember back in the days when I was reviewing medications in Western Australian nursing homes, and you could just see, for example, PRN or when required medications that were not being used, pain medications not being used on when required basis. On the other side, you had all these antipsychotics that were being prescribed, and you would wonder, well, how come these are not being used at all? How come there's no pain? But then you have these behaviors and these antipsychotics are being used. So we slowly started to, make that link. And this is how basically also PainChek, initially the idea on doing something about pain, this came through this sort of clinical practice experience. So it is a big issue because, as I mentioned before, behavioral symptoms, when they are identified, they're troublesome for residents, they're distressing for carers as well. But the underlying cause, which is pain, sometimes and oftentimes is not identified. So what happens is that we tend to treat the actual behaviors with antipsychotics, but not the underlying cause, or what's causing these behaviors. And in fact, we have some evidence from the UK actually that suggests that this leads to, there's a lot of prescribing of antipsychotics in the UK alone, especially in dementia. There's, according to Department of Health here, there's about 180,000 prescriptions of antipsychotics that are prescribed approximately in aged care setting. And again, according to Department of Health, about 80% of these prescriptions are prescribed. Prescriptions for antipsychotics are prescribed inadequately. So this is a big issue, Simon, because obviously if we don't identify pain, we're not going to treat it. But pain leading to that behavioral and emotional change that I mentioned before, due to inability to communicate what we need, is causing these challenging behaviors. And then we simply tend to treat those challenging behaviors with antipsychotics, and we should move away from that as much as possible. So we should really identify that pain, if pain is the key reason for those challenging behaviors, and like that we will reduce the inappropriate prescribing of antipsychotics, because antipsychotics, they have problems. First of all, even when they're prescribed, according to all the guidelines, they should be in dementia, they should be prescribed for a very short duration of time. They have a lot of side effects. The side effect profile for them is not good. Therefore, we should really minimize the use of these inappropriately prescribed antipsychotics.
80%. I can't get over that number. 80%
Yeah,
inappropriately prescribed. An astonishing and kind of terrifying number, to think that it's being done incorrectly more often than not is that's not a great set of circumstances by any stretch.
absolutely.
Mhm. Okay, so what I guess what's the impact of unrecognized pain on people living in care settings, and then also the care teams themselves as well? Because it's obviously it's something that if the person living in the care setting is having having the pain experience, however that kind of manifests itself, if they are expressing distressed behaviors, then that's obviously going to have an impact on the people around them. So talk to me about that point as well, because I can imagine that's quite significant given what we're talking about.
Absolutely. Well, recognizing pain, as I believe I've outlined until now, is very important. In fact, first of all, pain management is now a recognized fundamental human right. So, and in order to manage pain and therefore fulfill this fundamental human right, you first need to identify pain. And when we say identify, I think that includes its severity as well. Ascertaining what is the severity of pain is just as important as identifying pain, in my opinion, because once you identify pain, the having an indication on the severity of that pain guides us very much in terms of clinical decision making of how are we going to make an intervention, what sort of intervention are we going to make, etc. You're not going to treat mild pain in the same way as you would treat a severe pain. So when we recognize pain, obviously that's important, but we also need to ensure that we identify the right category, the right level of pain. And obviously the key problem of unrecognized pain is the fact that someone, for example, that lives with dementia, if they have pain that is unrecognized, then basically they suffer silently in pain, and that's what we don't want to happen. We can imagine a case which I'm sure for many carers out there listening and clinicians as well would agree is quite prevalent in practice. For example, you have a 70-year-old person diagnosed with advanced dementia. They experience increasing agitation, confusion, as well as other behaviors of concern or unmet needs. Then you'll see that that he has a long history of generalized osteoarthritis. Carers, family suspect they're in pain. They're unable to tell them. So this goes on and on in circles. So this is a very common example, Simon, occurring on pretty much daily basis in various practice settings. So we need to ensure that these cases are dealt with appropriately and treated in a timely and efficient manner to basically prevent all the subsequent complications of unrecognized pain. As mentioned before, pain is linked with behavioral symptoms, BPSD, or challenging behaviors as well. And the higher level of pain is associated with increased severity of these behaviors. This is very important because, as I mentioned, it results in an appropriate prescribing of antipsychotics, which also has an economic impact as well, in addition to all the side effects. But there are other reasons why we need to make sure that pain does not go unrecognized. There's more evidence emerging to support this. For example, people with chronic pain may be more susceptible with COVID-19. Particularly older people with comorbidities, and we know that generally people living with dementia also fit in this category. And we know that there's an association between pain and impaired immunity. So the longer you leave pain unrecognized, untreated, that's going to affect their immunity, lead to infections, etc. There was an interesting article recently that was published where researchers explored the association between widespread pain and dementia, as well as particularly Alzheimer's disease and stroke. This was the Framingham Heart Study, where widespread pain is basically, as you know, a common subtype of chronic pain, often linked with musculoskeletal disorders. They had 3 groups in this study: those with widespread pain, those who had other pain, and those who had no pain whatsoever. And they were monitored continuously from the beginning of their cognitive decline, as well as for clinical dementia as well. They were monitored for 10 years. They were monitored for stroke as well. So what they found was quite astonishing, I believe, because widespread pain, which they defined as pain above and below the waist on both sides of the body and skull, as well as backbone and ribs, what they found was that widespread pain was associated with an increase by 43% in all-cause dementia risk. So that's quite significant. This pain was also associated with a 47% increase in Alzheimer's disease. And there was nearly 30% increase in the risk of stroke. So this is quite significant. So obviously we need to make sure that we don't leave this pain unrecognized in this population group. And interesting, these findings were independent of age, the socioeconomic factors, the health status, behaviors, gender, etc. So that's something to have in mind. So there's multiple reasons why we shouldn't leave pain unrecognized. And as I mentioned before, the pain in a person living with dementia, it causes more distress to caregivers as well, in addition to affecting the person themselves. The study, which was recently conducted in Australia, found around 31% more distress to caregivers in the pain group category. So, and we know other clinical issues, including implications of pain and challenging behaviors. For example, staffing issues with safeguarding, etc. So these are all, Simon, very compelling reasons why we should not leave pain unrecognized, especially in those unable to communicate, such as people living with dementia, because if we don't recognize or identify pain, we're not going to properly manage pain.
There's so many implications, isn't there? There's the direct implications of pain, but then there's so many. It's almost like it proliferates through the experience of the person and then the people around them. You've got the misprescription of drugs, you've then got the cost impact of all of that. It's really quite wide reaching once you start to get under the surface of it. Now, I mean, you've shared some really useful insights for today, but if there was one thing care providers could do tomorrow to make a difference, like what's that one thing? If there's an actionable thing that people could take away, what do they need to do in these sets of circumstances?
Well, that's a very good question, Simon, and obviously a difficult one, because there's so much that can be done to make a difference. But I think first of all, providers need to ensure good clinical practice. So I think this is very important for someone with distressed behaviors. Multidisciplinary approach is very important that focuses on non-pharmacological intervention as well, not just medications. And additionally, we know that when you ensure good clinical practice in someone with these challenging behaviors, it also means that the first thing you need to do is to rule out pain. So ensuring good clinical practice is very important. But I think the way that the care providers can do that is if they leverage, for example, the power of technology and digitization. I think this is going to be key for them to enable them to achieve this easier, to achieve this good clinical practice easier, and they should leverage this. Embracing digital solutions, I think, is the way to go. I would focus on the recent Department of Health and Social Care policy paper for digital health. and social care. And it's interesting how they've put emphasis on, amongst other things, on these three key things, which is equipping the system digitally for better care. That means digitizing health and social care records. That's very important. Enhancing the impact on people providing the services, and that includes obviously training them in the right skills. And obviously use the technology, digitization, to support diagnosis, and that's to improve accuracy of diagnosis. I think thinking about the technology and digitization within this framework, I think is very positive, and care providers should do that. And there's already, Simon, examples of that happening in the UK. We have providers in the UK with successful integration of digital solutions. In this case, PainChek, but they've incorporated PainChek within a complex and multifaceted psychological intervention known as the Reconnect program. And they've already seen, within a 6 months period of time, they've already seen great improvements in terms of the outcomes as part of simply managing pain better, but also in addition having these other psychosocial interventions as well. So they've seen reduction in antipsychotic use and benzodiazepine use, which we know have a lot of side effects and they affect the quality of life of their residents. But they're also seen some staggering effects, like over 90% reduction in safeguarding events through these multi-faceted interventions, which also included pain management. So I think this is the message for care providers.
Brilliant, thank you, Kreshnik. Always really good to talk to you. You're a passionate man. You know your subject matter better than probably anyone else in the particular focus that you have. So thank you for sharing your insights today. It's been really helpful, and I have no doubt that this will be a really valuable piece of content for members of the Care Leaders Network.
Thank you, Simon. Always a pleasure talking to you. Thanks.